Here is our roadmap for today's rapid review. We'll cover the mechanics of shock, the 4 distinct classes, fluid resuscitation, crucial indices, massive transfusion protocols, and finally, transfusion complications.
Section 1, the mechanics of hemorrhagic shock. This is hands down the most common type of shock you're going to encounter in surgery.
You know, it's easy to look at a monitor and think shock is all about a drop in blood pressure. But at its core, it's defined fundamentally as hypoxia at the cellular level. If your patient's tissues aren't getting enough oxygen, they are in shock, period, regardless of what those initial vitals might be telling you at first glance. Here's a classic exam favorite that always feels a bit counterintuitive. A lacerated or partially cut artery actually bleeds way more than a fully transected one. Why? Well, when a vessel is completely severed, natural vasospasm kicks in and cinches it shut, which really reduces the bleeding. But with a partial laceration, that exact same vasospasm pulls the edges of the cut wide open. The result? Much heavier blood loss. Now, if hemorrhage happens around a surgical procedure, we actually classify it chronologically. Primary hemorrhage happens right there, on the table, during the procedure. Reactionary hemorrhage hits between 4 to 24 hours post-op. This is often because a surgical knot slipped, or maybe a blood pressure spike blew out a small vessel. And finally, secondary hemorrhage happens a few days later, typically because an infection caused the arterial wall to literally slough off. Moving right along to Section 2, the 4 classes of shock. Let's break down the severity of the bleed. This matrix brilliantly illustrates the clinical picture. To memorize the blood loss percentages, just think of a standard tennis match scoring system. 0, 15, 30, 40, and then it's game over. So, Class 1 is 0 to 15%, Class 2 is 15 to 30, Class 3 is 30 to 40, and Class 4 is greater than 40% blood loss. Notice how the treatment scales aggressively here? We go from simple oral liquids for a Class 1 bleed, which is essentially like donating blood, all the way up to massive, life-saving transfusions for Class 4. Definitely flag this one for your exams and everyday clinical practice. The absolute first clinical sign of Class 2 shock, way before blood pressure ever drops, is tachycardia. The body dumps a massive surge of adrenaline and noradrenaline to cause peripheral vasoconstriction and aggressively shunt blood to vital organs. That huge adrenaline spike is what drives the heart rate up first. So the big takeaway here is that systolic blood pressure does not fall until Class 3 shock. Class 2 is what we call the compensated phase. But once you hit Class 3, the patient has lost 30 to 40% of their blood volume. This marks the decompensated phase, where the body literally cannot mask the fluid loss anymore, and that's when systolic pressure finally crashes. All right, Section 3, fluid resuscitation and monitoring. Once we identify the class of shock, we have to initiate targeted fluids and rigorously monitor the response. There's a super important distinction to make here. If you want to know how much fluid to give initially, you've got to rely on central pressures like central venous pressure, or CVP, and pulmonary capillary wedge pressure. But if you want the best clinical indicator to tell you if your resuscitation is actually adequate and perfusing the organs, you need to carefully monitor the urine output. That said, modern medicine is always evolving. The single best new endpoint for measuring overall systemic perfusion isn't just urine output anymore. It's mixed venous oxygen saturation, or MVOS. Think about it. If the body is starved for oxygen because of low blood volume, the tissues are going to greedily extract way more oxygen from the passing blood. That leads to a much lower MVOS returning to the right atrium. Next up is Section 4, crucial shock indices. Let's do some vital clinical math to predict mortality and stability. While the standard shock index just simply divides heart rate by systolic blood pressure, the modified shock index divides heart rate by mean arterial pressure. Clinically, this is noted as the single most sensitive indicator of shock severity. And if you're calculating that standard shock index, pay really close attention to the ratio. Anything greater than 0.9 is a massive red flag. Large-scale studies show that crossing this 0.9 threshold strongly correlates with much higher patient mortality, demanding immediate aggressive action. Section 5, massive blood transfusion protocol. This is what we trigger when things get extremely critical.
When a patient hits class 4 shock with unrecordable vitals, we've got to pull the trigger immediately. We officially define a massive transfusion by any of these 3 rapid volume replacement criteria: replacing the entire circulating blood volume in 24 hours, giving more than 10 units of blood in 24 hours, or in extreme trauma emergencies, rapidly infusing more than 4 units of blood products in a single hour.
But here's the catch. You can't just pump in packed red blood cells. To prevent a deadly dilutional coagulopathy, where you basically wash out the patient's ability to clot, we have to deliver packed RBCs, fresh frozen plasma, and platelets in a strict 1:1:1 ratio. This mimics whole blood and gives the patient the clotting factors they desperately need right then and there. Finally, Section 6, transfusion complications and coagulopathy. Giving that much stored blood that fast is life-saving, for sure, but it comes with severe risks.
These complications are highly testable, so pay attention. First, rapidly infusing cold, stored blood instantly leads to hypothermia. Plus, blood banks use citrate as an anticoagulant. A patient in shock just can't metabolize that citrate fast enough, leading to citrate toxicity. This severely depletes calcium and magnesium, causing dangerous hypocalcemia. You're also going to see severe metabolic shifts, including massive potassium fluctuations and extreme acid-base swings.
You've also got to be able to rapidly differentiate these 2 major pulmonary complications. TACO is exactly what it sounds like: transfusion-associated cardiac overload. It's a volume overload that puffs the patient up, and you can treat it effectively with diuretics. TRALI, on the other hand, is transfusion-related acute lung injury. It's a severe immune-mediated lung injury that mimics ARDS. It hits within 6 hours and is triggered by anti-HLA antibodies in the plasma. All of this builds into the most dreaded complication of all. Ultimately, the most common cause of death in massive transfusions isn't lung injury, it's coagulopathy. It forms a deadly, self-feeding cycle called the terrible triad of trauma. Think about it. The patient gets cold from the blood, which worsens their acidosis, which physically stops the blood from clotting, which leads to more bleeding, meaning they need more cold blood. It is a literal, lethal downward spiral. Because of all these incredible risks, modern perioperative guidelines are super strict now. Following surgery, you generally only transfuse if the hemoglobin drops below 6. If it's sitting between 6 and 8, you only give blood if there are active, ongoing losses. And if the hemoglobin is over 8, there is absolutely no indication for a transfusion at all.